Oh, thank you. I'm so excited to be here with you for the 27th Annual National Forum. And I know that there are a few of you out there who have been to all 27 with me. And I know that there are many out there for whom this is the first National Forum. How many of you are here for your first forum? Would you stick? Wow. It's so great to be in this room with you all. And what it does, it brings me joy. It makes me filled with gratitude to be in a community like this of people who are new to IHI and new to the forum, and all those who are maybe more experienced, shall I say, the ones who've been here with me for 27 years. It fills me with joy and gratitude because of how far we've come in these 27 years. And also to think about where we're heading. And I know how exhilarated we'll be when we get 27 years from now to look back at the changes that start here today. My gratitude comes from this community. When we began 27 years ago, our mission was to improve healthcare. And we went outside healthcare and we brought in expertise from other industries, and we began to transform safety. We began to look at flow. We began to think that we could bring in measures, we could bring in improvement tools to transform healthcare and create safety. We wanted to learn from the best and then share those lessons broadly so that everybody, everywhere, could benefit from those lessons. And today, we're taking those lessons from healthcare and even moving farther upstream to work on health. And this is truly exciting and gratifying for me. We've also built this enduring global community. We're here from 52 countries in this room. And there are many others watching on video conference. And the lessons that we're building around the world are equally going to benefit every single patient you touch when you return. But we still have lots to do. We're seeing increasing burdens of disease. We're seeing the impact of social determinants on health. And that means that our job is still pretty big out there. We need to finish the transformation, I think, of creating better practices, better hospitals, and better systems. And then we need to move on to think about how do we create better health in our communities. We need to ensure that every patient can say, I get exactly the care I want and need, exactly when and where I want and need it. And we need, I think, to create our systems that are really capable of producing the IHI triple aim. We want to be able to say that we're together as healthcare people improving health, we're creating better and improved healthcare, and we're doing it at a lower cost. And I know that the assets to get to the triple aim are here in this room today. So that's what fills me with gratitude. But why did I use that word as my theme? Well, it turns out that gratitude is a form of social capital. What it does is it's a way to see kindness and compassion and empathy. And when you feel gratitude, these feelings allow you not only to feel better about the work that you're doing, but it helps you to pay it forward. Gratitude is about paying it forward. It builds interdependency. People working together. You feeling gratitude means that you're grateful for the work or the challenges that another person has helped you to face. It builds trust and it fortifies resilience. Gratitude then comes from knowing each other. And that's what we're all here about this week. You'll meet people and you'll get to know people who you've never met before. But we're going to create a community. So it's a simple thing, it sounds like, getting to know someone. But it turns out that in order to feel gratitude, as I am right now, you really need to get to know people. The National Forum is a tremendous opportunity for you to do that. I hope you all go home with 10 new friends, because those relationships are going to help you when you get back to improve health care in your systems or to improve health in your communities. It turns out that these relationships are helpful, and that helpfulness outperforms intelligence every time. Helpfulness outperforms intelligence. It means that we're smarter together. And so that means that this idea of building relationships is going to be critical to getting the energy that we need. That's why I feel so committed and so gratified by all of us today. It also turns out that gratitude is good for your health. So if you, every single day or every night before you go to sleep, Stop and think about one thing that you're grateful for. You'll be healthier. It reduces stress levels. It makes your sleep better. It gives you more energy. So it turns out that gratitude is a really inexpensive and helpful medication for us all. And that's why I'm so grateful. This morning, what I wanted to do is express my gratitude. I wanted to look back over these last years and share with you some of the lessons that I've picked up. And I want to pay it forward by giving you some tools and some ideas, some people that you might want to meet so that you can pay it forward when you get back. So I'm going to share with you this morning 5 lessons that I've learned. I really had 15, but the staff wouldn't let me stay up here all morning, so I had to cut it down to 5. But here are my 5. The first one is we've made a lot of progress in how we improve. The second is how we hear the voice of the patient. The third is how we teach and learn and see. The fourth is how we care. And the fifth, and maybe the most important, is how we lead. So my first lesson, how we improve. Decades ago, the way we improved was we had a quality assurance department. Do you remember that? And it would be a department of experts who would be measuring quality. They would be identifying the gaps, and then their job was to run projects to help to close those gaps. IHI was founded some 27 years ago in a way to move beyond quality assurance departments. We always think about Dr. Deming's admonition that quality is everyone's responsibility. And we began by bringing those tools in from other industries, because what we were realizing is that the quality assurance department couldn't get the kind of results alone that we needed. We needed to engage every doctor, every nurse and pharmacist and clinician, every leader in understanding their role. We always say everybody's got 2 jobs. The radiologist, and my job is improving care. And it's that idea of building out the assets of improvement across the entire organization that's going to allow us to get where we need to get. So we founded IHI to take quality out of that silo, that department, and begin to spread it. And for 5 years, we taught people, we had this growing cadre of very enthusiastic people sitting in a room much smaller, but much like this one. And then one night, over dinner, 2 of my heroes, Dr. Don Berwick and Dr. Paul Batalden, were sitting over dinner, and they decided to up the ante. What they decided is that we should get quality to be everybody's job. And what emerged from that dinner was a sketch on a napkin. Paul actually started to draw a different way to think about improving, not in a department, but in a collaborative. And they went back and forth, Don and Paul, and with some guidance from Tom Nolan, who's a mentor of mentors for all of us, they laid out the basics of this new approach. And then from that emerged the idea of the Breakthrough Series Collaboratives. This is the 20th year of the Breakthrough Series Collaborative. And we've been running these collaboratives across the United States, around the world, with great results. We began by working on safety. We looked at flow and access. We began by reducing unnecessary cesarean sections here in the United States. And the idea of coming together brought everybody's ideas, everybody's experiences and challenges, and really accelerated the pace of improvement. We called it the Breakthrough Series because we needed to break through the status quo. We needed to get everybody's brains in the room and really begin to create a new marriage of clinical expertise and improvement science. So every time you're in a Breakthrough Series meeting, you're talking about improvement tools, measurement, control charts, and you're talking about the best of clinical science. And together, these people experience gratitude like you've never seen. I am so grateful to Paul and Don for breaking through in that way. I'm so grateful for API and for all of the improvement advisors here in this room who are bringing improvement science to marry with the clinical expertise, to all the staff at IHI who are rolling this out, and to all of you who've worked in collaboratives around the world. And the model still works. So looking back, we've had a big transition, but today we're still using Breakthrough Series collaboratives very effectively. In Ghana, we're working with our partners to use a Breakthrough Series model to decrease mortality in children under 5. Project 5's Alive has had dramatic reductions, as you can see, a 31% reduction in mortality in children under 5 across the entire country. And looking at the projects in Brazil, we're using the collaborative model with our partners Einstein Medical Center in Brazil to increase the number of women who are delivering babies naturally, decreasing cesarean section rates. It's a complicated social problem, but you can see that in just the first few months of the collaborative, we're seeing wonderful improvements, exciting improvements across Brazil. We're also seeing new kinds of networks. The Improve Care Now network, as an example, is a network, a collaborative of patients and families with carers and researchers. The Improve Care Now network, in just 5 years' time, has improved the remission rates for children with inflammatory bowel disease from 55% to 79%. So today what we're seeing is not only does the collaborative model still work, but the power of adding patients and family voices into the learning network is producing better and faster results for us all. We're seeing leaders in Scotland take on a new kind of collaborative to decrease the rates of stillbirth in Scotland. And what they realized when they got together is it can't just be the clinicians in the room. We've got to engage with women much earlier in their pregnancy. We've got not only to bring the best clinical expertise, but we've also got to marry in multidisciplinary approaches. And in Scotland, we're seeing, again, dramatic decreases in the rates of stillbirth in just a very brief period of time. What's so exciting is I heard from a nurse, a NICU nurse, who said, I'm so gratified. I feel gratitude because I'm seeing so many tiny babies. And she said, before, these babies never would have made it to me. So I know that the model is still working really well. And as Gary said, we're launching 2 new kinds of collaboratives. The first one, the 100 Million Healthier Lives Collaborative, is, again, an exciting innovation in that it's bringing people from all over the communities to work on this unprecedented goal of 100 million healthier lives. The vision is so exciting to move from running a collaborative in healthcare to thinking in a totally different way about health. And when you're in those meetings of 100 million healthier lives, you're sitting with school teachers and firemen and public health people and healthcare people, citizens in the community, people whose health is suffering and people who are healthy, everybody coming together for 100 million. And we began this last year just in the idea that we would start in the United States. We certainly have health problems and challenges here. But already in 1 year's time, it's spread to Brazil and to England, to Sweden and Scotland, to Australia and Uganda and Canada. It's this idea that a collaborative can produce energy and results that perhaps we couldn't alone. I know we couldn't alone. And the other collaborative that Gary mentioned, the IHI Leadership Alliance, is equally exciting. To see these leaders coming together and not taking the traditional approach, which is we would prepare the change package and then the leaders from a hospital would adapt it locally based on their culture and their particular needs. This is different. This is leaders coming together, and they are co-producing unbelievable ways to think about solving these intransigent problems. These leaders are co-producing the solutions to complicated things that we've wrestled with for years. It's really change from the inside out. These leaders are saying, we're the leaders in healthcare. We shouldn't be waiting for payment reform, or we shouldn't be waiting for policy change. We're the ones who know best how to partner with our patients and their families. We're the ones who know healthcare. We should be stepping in to be the change that we want to see in the world. The vision of the Alliance I love. It's care better than we've ever seen, health better than we've ever known, cost that we can all afford, every person, every time. And what the leaders are doing is they're publishing these radical redesign principles. I'm going to give you a little homework, and that is, when you go home, print off this page of radical redesign principles and just tape it next to your desk, because I know when you get back and you start to face some of the unsolved problems in healthcare, you might feel discouraged. But one, remember, you've got a group here. helpfulness is better than intelligence. And second, you've got these radical redesign principles. And everybody who reads them is inspired to say, I can do something totally differently that's going to produce this better result. So first homework, print out the radical redesign principles. They're so exciting. And you'll find throughout this week examples of every one of them already in action. We're seeing transformation happen. And then looking ahead on how we improve, I see that we're going to need to be creating even more global learning networks. I envision a day when you face a problem, you can go onto the website, or you can link in with another country who solved that problem. You'll be able to see global data. We'll have these learning networks and collaboratives that are multi-professional, multi-country, and simultaneous. This idea of learning networks is really going to be an important asset for us all to build on in the future. And I think we'll see improvement skills taught in grammar school. I think that kids will learn resilience. We'll create collaboratives of kids who will begin to take on their own health challenges, and we'll start to see totally different generations and professions coming together to solve these problems. So multi-professional teams, virtual learning sessions, the future is really right here for us to begin to take the next step on how we improve. The second lesson that I wanted to talk about this morning is how do we hear the voice of the patient? In the old days, we would think that best care was taking care of a patient, listening, prescribing, following up, making sure that the patient could follow the prescriptions that we ordered. And we basically were, in the old days, working to optimize the encounter. I see the world as totally different right now. I think that at Paul Batalden's urging, we're not producing a service. We're co-producing. We're not producing a product. We're co-producing a service. We're partnering with patients to think in a totally different way. It's a massive and vital mind shift to go from designing a product to co-producing a service. Today, many board meetings start with a patient voice. We have patients here at the forum. Patients, will you stick up your hands? The patients are our inspiration. They'll be sitting in your sessions and they'll be giving you ideas. This forum wouldn't be what it is today. Healthcare wouldn't be what it is today without us more hearing the voice of the patient. And we still have yet a far way to go, I think, on this. I would say that in my 20 years at IHI, the most gratitude I feel is for the patients and the family members. It's been their voice, the meetings, the interactions that has inspired me every single day to keep on going. I have a friend, Annie Levy, a visual artist in New York, is helping me to think about this in the future. She's saying that we still don't hear the voice of the patient well enough. And Annie has got a dramatic way of helping. What she does is she gives people a camera and she says, take a picture of what's important to you. Because when I see what you see, that will help me hear what I need to hear. Annie recently did a project where she gave young kids with cancer a camera. And she said, take a picture. And the picture then will tell me a story. And I wanted to share with you a couple of those stories this morning.
So I was diagnosed when I was 8, and this is a picture of when they first took my bandage off, and the first words out of my mouth were, "It looks like a baseball." And then 2 days later, my best friend at the time came and visited me. He said, my mom was thinking, oh God, hope they're not afraid of it or anything, and first thing out of his mouth was, "Cool, it looks like a baseball." And ever since then, the first time I saw the picture, it freaked me out a little bit because I wasn't used to seeing it. But now it's a funny story, and it kind of makes me laugh every time I hear it.
So the interesting thing about kids is that I think they always think like kids no matter what, whether they're going through something medically or not. For example, one of my memories of going to the hospital is my mom would always get me a Beanie Baby every time that we went. One of my memories from the day I had brain surgery was that one of the doctors, before I went in, she had me draw on her mask so I would recognize which doctor was her amongst all the other ones. And this is also from when I had my surgery. As an 8-year-old, I wondered how they were going to put my head back together. And so the answer I came up with was glue.
This photo I took is for the my diagnosis part. I took it to depict who I am now and who I was before my cancer diagnosis. I had a brain tumor, supracellular germinoma, and it took away a substantial part of my vision. And without my glasses, I'm blind. So it was a real challenge for me. And I see it now as kind of a retrospective image because it's me looking into the past and the future and the present all at once.
My mom is the strongest person when I had cancer. She is someone I look up to because she never brings me down. She's always by my side, and she's my hero when it comes through my diagnosis and all the BS that I've been through in the hospital. She's always there. I can always count on her. She's the only person who knows English in my family, and I respect that because she's a smart person. What keeps me going is my creativity, and in this picture I created origami with money, and I think it's pretty awesome. It represents Mount Rushmore, but I call it Mount Awkwardness. Awkwardness, 'cause it's awesome.
So I think what you see in Annie's work is that by giving someone a camera and saying, show me what matters to you, that we see a whole different side of the assets of these kids. There are more videos that I wish I could show you just to demonstrate the strength that these kids bring. But often, if we're on the clinical side, we don't see the assets. We might not see this little girl's mother as being the most important person in her life. But I am grateful that more and more we're seeing the voice of the patient heard. The voice is driving design. At Bellin Health in Green Bay, Wisconsin, they've recently redesigned the entire journey of a patient who's going through cancer care. And they listened to the voice of the patient. They watched a patient design the journey so that they could see what was it like, not only implementing excellent clinical guidelines, but what was that moment like when the patient heard what was often a devastating diagnosis? And what is it like when, from my experience, what people are saying is the most critical question in the cancer journey, which is what's next? And then what will the aftercare look like? When Bellin Health redesigned this whole journey through the voice of the patient, they're producing incredible clinical outcomes and incredibly empathic care. Recently, I was in Singapore, and I met an incredible leader, and he was listening to the voice of the patient. He said this to me. He said, the sicker the patient, the fewer the providers, the fewer clinicians the patient should see. The sicker the patient, the fewer clinicians the patient should see. He was saying it's up to us to take on the burden of coordination. And at Cincinnati Children's, where I have the great honor to serve on the board, every child is assessed for medical complexity and social complexity. And when the patient reaches a certain threshold, they're assigned a navigator to help the patient and the family on their journey of care. This is leaders hearing the patient's voice. This is leaders stepping in to say, we need to take on the burden of coordination. Or as my friend Victor Montori says from Mayo Clinic, we need to produce minimally disruptive medicine. What we need to do is say, if we can't decrease the burden of the illness, at least we can decrease the burden of the treatment. And so I'm so grateful that people are stepping in and saying, we as leaders won't operate only in a silo anymore. We're going to design the care process and journey through hearing the patient's voice. Over the past few years, you've heard me talk about Susan Edgman-Levitan and Michael Barry's imperative to us that we move from not only asking what's the matter, but also asking what matters to you. And you might remember last year when I was up here, I shared with you the story of Jen Rogers, a nurse from Scotland who was sitting out in the audience at a forum just like this. And she heard me say that we need to move to what matters to you. And she went back to her pediatric hospital in Glasgow. And now every single patient there takes a piece of art paper and creates a picture for their door that says what matters to them. And I can tell you from Jen Rogers sitting out there in a forum audience just like you, and her taking it back and spreading it across her entire hospital, this is now spread around the world. And not a week goes by that I don't get an example from somewhere in the world. Recently, I got an example of what matters to me from Brazil, from a nurse who felt like she couldn't be heard, even though she was a nurse in that hospital. And when she was a patient, she said, I'm going to take a piece of paper and I'm going to make what matters to me, and I'm going to put it on the door. And Camila said that's what made her heard. And there's another example from the UK of a patient, a woman named Barbara, who's 79 years old. And she was repeatedly readmitted to the hospital after falling at home. The staff thought that they knew her. They said she lives alone and she uses a walker and she's becoming more and more frail. She was withdrawn, and at one point Barbara said, I've had a good life, but I'm done. And the staff started thinking that maybe they needed to give her antidepressants. They started talking with the physicians about an order for medications, and they started making plans to admit her to a nursing home. One of the nurses went in and said to Barbara, what matters to you? And the staff was blown away by what they learned. They learned that she had lived in Rio de Janeiro for 42 years and that she spoke fluent Portuguese. They found out that she had flown in the Women's Air Force in World War II and that the Queen of England had honored her with an MBE. With that information displayed on her door, every doctor and nurse, every housekeeper started coming in and saying, Barbara, tell me about your life. I never knew this about you. The conversations totally changed the interaction with Barbara. She started to work with the therapists. She'd light up every time someone would come into the room. And one day she said, to the staff, I'm ready to go home, and she did. So that's the difference that I think one person, Jen Rogers, can make, and spreading that around the world. So I encourage you to think about this. Recently, I heard from Jason Leach that a new hospital is opening up in Glasgow, and every single one of the 1,109 beds has a What Matters to You sign on the door. Every single patient will have the same voice that Barbara had, and that's going to change the interactions. That's going to give her a different sense. It's going to give every patient a different sense of how they can take better care of themselves. In the future, looking ahead, I think we'll all take my friend Chris Moriarty's advice. Chris says we shouldn't ask a patient with the hand on the door handle, do you have any questions? We should sit down next to the patient's bed and reach out and touch that patient and family member and say, what questions do you have? In the future, I think every electronic medical record will have what matters to you built right into it. We'll have all of the social context, all of the challenging circumstances, and all of the assets of the family built in, because those things are just as important as the clinical indicators. And we'll live Paul Batalden's challenge to co-design care with patients. And I think that's going to help us, guide us to design on every step. So that's the voice of the patient. We're doing better. We still have a long way to go. My third lesson is about how do we teach and learn and see. In 1974, Victor Fuchs wrote this amazing book, Who Shall Live? A landmark application of economic thought to health and healthcare. And in the book, he said, doctors are the captain of the ship. That was in 1974. 20 years later, he created a revision, and he demoted the physicians to co-captain of the ship. And today, Victor Fuchs says, they aren't co-captains anymore. He said they're team members. He said that teamwork is the most critical element of us making these kind of changes that we need to make. Better outcomes are going to be reliant on great teamwork. Being an independent, even a very skilled practitioner isn't going to do it anymore. We need to teach and learn together how to work in multi-professional teams, how to engage with patients and families. 2 years ago on this stage, I talked about flipping healthcare. And I was encouraging you to think about learning some of the lessons that we've learned from education. When we saw teachers who said that they've moved from being the sage on the stage to the guide on the side. And I was encouraging doctors and nurses then to go back and flip healthcare, to think about we're not the sage on the stage anymore. Writing prescriptions and giving them to patients isn't good enough anymore. It's guide on the side. How do we come together with our patients and families and co-produce the kind of care and outcomes that we want? When these teachers went from being sage on the stage to guide on the side, it allowed them to see the silent failures, the kids who were challenged, the kids who had trouble coming up to the front of the room. And just like that, what I am seeing amazing examples of those of you who are flipping healthcare in these last 2 years. I'm hearing, again, examples from around the world where people are saying, I'm not the captain anymore. And they're revising the way that they practice in their office. They're revising the way that they give care in hospitals to be the guide on the side. If we're going to flip health care, we also need to flip the way we teach health professionals. And I'm really excited about some of the changes I'm seeing. At Hofstra Northwell Medical School, just graduated last May, their first class. They've radically redesigned medical education. The focus here is on teamwork. The focus is on patient communication. The focus is on engaging patients in co-designing their own health. I am going to put a link to a video in my slide set. So when you go back, this is your second homework assignment. There's a PBS video called Doctors of Tomorrow. And I'm going to ask you to promise me that you'll watch every one of the 27 minutes. It is a brilliant depiction of the future of medical education, and it's here today. What you'll see is that these medical students spend the first months of their medical education out becoming certified EMTs. The first patients they see are in the field. The first teachers they have are EMTs and firefighters. And you'll watch the journey that they go through. It's an amazing 27-minute video, and I encourage every one of you to watch that one. At Penn State, we're seeing first-year medical students assigned to be patient navigators. And they're going out into the homes, and they're seeing things that they'd never see before. They're seeing, does the refrigerator have food in it? They're looking at the patient, does the patient have transportation to get to medical care? They're finding out, does the patient have the money, and do they understand what a gluten-free diet is? It's transforming the way that they think about their role. University of Texas in Austin is creating a new medical school, and a big part of the curriculum is about population health. And at Case Western Reserve, one of the most popular classes is called Life Over 90. It's taught by 6 people, all over 90 years of age, who are teaching the medical students what it's like to be over 90. It's bringing joy to the people over 90, and it's bringing great joy to the medical students. And some of them are saying that they're actually attracted to go into gerontology when they never would have before, because they see the impact that they can have on patients' lives. In all health student curricula, we're seeing that we need to not only teach medical care, but we also need to teach about the social determinants of health, because, as you all know, health care has such a little impact on health. So we really need to change the curriculum. I love that ACGME recently started to require that all residency programs teach health, or how to reduce health disparities by using quality improvement projects. That's a fantastic step forward. We can start to reduce those disparities today. We can start here in this room. And one of the people who's here in this room with us today is a physician from Gainesville, Florida. Her name is Nancy Hart. And Nancy took on this challenge herself. She was curious about some low birth weight babies in one part of Gainesville, and that led her to creating a mobile van to bring healthcare into a particular neighborhood. What I love about the mobile van is that it's got 3 missions. The first one is to take care of the underserved in that neighborhood. The second one is to create a culture of service. To me, that speaks to gratitude. And the third one is to educate the medical students in a totally different way. When you look at the faces of these medical students, you see gratitude. And what Nancy told me is that Even though these kids are in Florida on spring break, they stay and take care of the patients in the van rather than go to the beach. They feel gratitude by the care that they're giving. And I think I've just listed here a couple of the examples of the answers that they gave to Nancy when she said, reflect on your experiences in the mobile clinic. What did you learn in the van that you never learned in the classroom? And look at these things. These are just a couple of examples. There's many, many lessons that they describe. But they learn how to recognize and deal with intimate partner violence. They learn about transportation challenges. They learn about how to do diagnostic testing in a low-resource way. They're learning lessons that they said they never learned in the classroom. And this is an example, I think, of flipping healthcare, so that we can start to see the challenges in a bigger way and start to equip these kids to go out and take care of the patients of tomorrow. Recently, I was in Singapore, as I said, and I visited KTP Hospital. And I said to the leaders who were taking me around, what are you proudest of? And they taught me how to see something very different. They brought me up to the dementia unit, a unit that's caring for people who are way too sick to be independent and outside of the hospital and in the community on their own. And the first thing they did was they brought me up to this sign and they said, look at this, 861 restraint-free days in a dementia unit. 861 days. I was shocked and I said, how did you do it? And they said, we're going to teach you how to see. They brought me to this place, and you can see that I have had a picture taken of me in front of this place. Where do you think I am? I'm not in front of a bookcase. These are the doors to the unit. They said that the most frequent cause of people needing to be restrained is that they jump out of bed and they run out the doors. Anytime the doors to the unit open, patients get out of their bed and they go out the door. It's an instinct. So rather than just respond by restraining, they said, let's see what are the prompts that cause people to get out of bed. When you think about restraining, what are you seeing? And so what they decided to do was to create the bookcase look on the doors. So now I'm standing in front of the doors to the unit that looks like a bookcase. They put a book on everybody's bedside table, and now no patients get up and walk out the doors. It's a great example, I think, of learning to see in a different way, really digging deeply into the root causes rather than the instinctive reaction of restraints. So I think that one of the most exciting ways for me to see this new ways to teach and learn is the IHI Open School. Today, we've got over 265,000 students from 78 countries. And I can tell you, I am filled with gratitude every time I meet with the students. We've got about 500 students here today. And it really is the future of healthcare leadership. You may have run into them already. They're standing up and presenting projects that they're doing that are solving problems that many of us more experienced people have been living with for many decades. And it's a great thing to watch them learn all on the online improvement skills and leadership skills and person and family-centered care. They're totally taking on a new curriculum all on their own time. And this legion of improvers is already changing the way that we think about this. So I think going forward, I think we'll value the assets of a team in a totally different way. We'll train in teams. We'll train multi-professionally. We'll train people in ways that they'll be able to engage with patients. We'll teach them how to co-produce care. We'll change the way that people experience what it's like to live with the social challenges in the community. I think we'll also teach kids how to use technology to communicate in a real-time way. We'll teach them how to find joy by using all of the assets in a team. And I think that patients and families are going to be the most valuable faculty, the most valuable teachers of all. Recently, we were in Cuba, and I came across a group of young children who have diabetes who decided that they should be the teachers. And they took over the radio station, the television station, to teach other kids that it's not so bad. Everything's going to be okay.
diabetes no nos invalida de tener una vida plena, e igualdad de condiciones y oportunidades.
Convivencia Fílmica es un proyecto donde aprendemos a crear nuestros propios audiovisuales.
Y con ellos podemos mostrarles a otros niños a vivir con esta nueva condición.
Desde el inicio somos protagonistas de nuestros audiovisuales.
Desde que surge la idea hasta que terminamos el material, trabajamos en equipo.
Siempre con la ayuda de los profesores y doctores.
No ser discriminado, saber cuidarse, tener una dieta balanceada y practicar deporte, siempre es lo más importante.
¿Quién mejor que nosotros mismos para explicarle a otros niños cómo pensamos y cómo es nuestra vida?
Aprendamos a vivir con la diabetes. Somos iguales, no diferentes.
Eduquémonos más para vivir mejor.
I love that the kids say, with the help of doctors and nurses, we'll teach all these other kids how to take care of their diabetes. So my fourth lesson is new ways that we've learned to care. And 20 years ago, we gave care to patients in our places, hospitals, clinics, and offices. So much has changed now. We're giving care with patients in all settings. And we're using new methods. In the old days, we used to prescribe medications. In the new days, we're prescribing different things. Now, I might have to translate a little bit here, but Dr. Robert Czar in Washington, D.C. is prescribing POCs. I know my Boston accent might be a limiting factor here, because when I was doing the run-through, the staff thought I was saying that he was prescribing POCs, P-O-X, but I'm saying he's prescribing POCs. Okay? So what he's doing is he realized that his panel of patients was becoming more and more obese, more and more sedentary. So what he did was he created a program called DC POC Prescription. And he said, I need to prescribe POCs. So what he did is he's created a GPS system, linked it into his patient records. So when he asks the patient a few questions or he sees a couple of indicators in the patient's record, he can then just figure out which patients need a POC prescription and which POCs he should prescribe. It's very different, I think, than prescribing a med. He's prescribing POCs. There's another new model called Riding, Not Ritalin, that aims for kids with ADHD. And the prescription here is that they ride bikes and that they ride them together. In a very short time, the program has dramatically reduced reliance on medication. It's improving energy, it's improving health, and it's prescribing bikes, not medications. And Rishi Manchanda, who's one of my visionary heroes in healthcare, has designed a new way to think of, it's a kind of a new role in healthcare. He calls it upstreamists. And what Rishi's saying is that prescribing prescriptions downstream isn't the right answer. Like Nancy Hart, we have to go upstream to prevent these kind of problems if we're going to get to the triple aim. So I think another way for us to think about it is new people who can provide health care. In Jersey, in the UK, there's a great program called Call and Check, and they're using an underutilized resource in the community to connect with people, especially elderly, who are socially isolated. What happens is they're using postal workers or mailmen who visit these houses every day. And they've trained up these mailmen to have interactions with these socially isolated people, and it's changing their lives. They're not only delivering prescriptions, but they can make arrangements for groceries. They're trained how to have interactions that are affirming and to assess patients who might need further help. What we're seeing is that the elderly people love it. They so look forward to these brief little interactions every single day, and the mailmen are finding joy in work. The model's now spreading to Ireland and Finland, and I love to see this use of everybody as kind of a healthcare leader. At Kaiser Permanente in San Diego, they're using lactation counseling on cell phones. And Dr. Jo Hiatt says this. She said, when breastfeeding isn't going well, there's a sense of urgency because the baby's crying and the mother's frustrated, and that's the moment when breastfeeding often stops. But if you can get an in-home app that will support the mother through those moments, you can, if those of you who have done this can remember the moments of frustration. And if you can simply call in and have a quick consultation, she's finding that the breastfeeding rates are higher, that this is solving a problem in the moment, using technology to have an instant interaction at the moment when care is needed. In Cuba, we found that 83% of women are still breastfeeding after 6 months and over 63% at the end of a year. And I love what they say there. They say that breastfeeding is the first immunization. So they're saying to mothers, it's so important because this is the way that you begin to protect your child's health. That's a different way to care. In the future, I think we'll teach health and healthcare in the first grade. I think people will start to understand their own responsibility and their own impact on health. We'll follow Trevor Torres' lead. Trevor, as you remember from my presentation a few years ago, is saying that I'm the CEO of my own health. And we'll probably have freshman year bundles. We'll have not only ICU bundles, but freshman year bundles to avoid the dreaded freshman 15. Or we'll have turning 70 bundles for how to keep you vital and elderly, vital at home when you turn 70. We'll use revolutionary technology, I know, to track and predict and prevent health problems. It's going to be a different way to care. And my final lesson is how we lead. And as I mentioned, I think that the biggest changes in healthcare leadership have started right here. It used to be, when I started out, that you developed your own leadership style. You thought about what kind of a leader do I want to be, and then you use those capabilities to manage people and processes and systems. Today, it's a very different challenge. Today, the best leaders are seeing that it's not all about them, that leadership is seeing all of the assets in your staff. This is the first time in history when a leader is managing 4 distinct generations in the same workforce. And the generations have different values. They have different ways to think about work and life. They have different ways that different things that motivate them. And it's our challenge to create multi-generational teams, multi-professional teams that thrive. That's a very different way to think about leadership. Leaders need to create great improvement skills. In the past, leadership was about telling the staff, fix and forget. Go out onto the floor. If you see a problem, the med isn't there, the equipment's broken, your job is to fix it and then continue on. That notion of fix and forget is admirably carried out by doctors and nurses and pharmacists every day, but it's taking a toll on the staff. Every day it's the same things, the same problems. I'm suggesting that new leadership models go from fix and forget to, as our senior fellow Steve Spear would say, see, solve, and share. Build in your staff the resilience and the improvement capability to solve the problem on the front line. But leaders need to see the accumulation of the problems so that they solve them on the system level. And as leaders take on the share part and solve the problems at the system level, we're seeing really great joy in work. It is the leadership challenge to build that capability, but take on the ownership for see, solve, and share. The best leaders today, I know, hire people. I know everybody in this room has a high IQ. We all know that people come into healthcare with a high intelligence quotient. And increasingly, what we're seeing is that leaders are recognizing that EQ is just as important. The emotional quotient is critical in healthcare. But I'll tell you what I think is the most important skill, and that is CQ, curiosity quotient. I've learned that curiosity is the thing that brings new ideas. It's the thing that helps us to solve all these daily problems. At IHI, I hire for CQ. Curiosity is magic. It's a special sauce. It's the most important asset, I think. When we're in the pace of change that we're in right now, we need CQ like we never have before. I had an experience this year when I got to test out my own CQ. I got off a plane in Hong Kong, and I read a little newspaper article about a thing called dialogue in the dark. And I got a fellow curiosity person, Joran Hendricks, and we went over to see what was going on there. It was a place where we arrived, and they were going to teach us the experience of being blind, being totally blind. They gave us a cane, and they led us into darkness. And for an hour and 15 minutes, we walked through darkness. We had a guide. Her name was Eunice. And as I started to walk down the first hallway, she said to me, Maureen, you're heading off to the left. Don't go that way. And then she said, Joran, you're about to go up a step. Be careful. For an hour and 15 minutes, she led us on a journey of walking over grass. She led us walking into a movie theater and trying to find a seat, and that's very difficult when you can't see. We went to a restaurant and ordered a drink, but actually had to pay with money that we couldn't see. We crossed streets. We looked at all of the challenges of being blind for an hour and 15 minutes. And at the end of it, when I sat down, I realized how stressed I was, but I also felt something quite different, and that was joy. And I said to Eunice, Eunice, you can't see, can you? And she said, no, I'm totally blind. Here, the greatest teacher I've had all year is somebody who couldn't see. And when I talked to Eunice about her life, she said she found great joy in teaching people, but she said the biggest frustration that she experienced is that she couldn't find a job other than this one. People didn't trust her. She led me to a place of curiosity, to a place of joy, and I want you to all learn that leadership is about seeing all the assets of a person, because that's what Eunice taught me that day. I think ensuring joy is the role of leaders. I think you have all heard that you can't give what you don't have. And if you're not joyous in your own work, you can't create joy in your staff. It's our job, I think, to really create joy in staff. It's about building resilience. I think it's cruel to show quality data transparently if you haven't built the improvement skills to close that gap. So I think that the final messages for me today is to think about leadership, to think about joy, and to think about innovation, because the problems that we've got today are big and we've got to solve them. A lot of people are telling me that there are too many innovations, there are too many quality improvement projects, and it still is critical that we build that skill. But I will leave you with a few other things, and that is one of the best ways to get innovation to speed up in your organization is for leaders to focus on Xnovation. That is getting rid of all the waste, the meetings, the things in our organizations that add no value to our staff's lives and to our patients. In healthcare, we're terrible at Xnovation. We just keep bringing in new things, new procedures, new equipment, new guidelines, and we never Xnovate. So I think if you want to create a really rapid tempo for change, we've got to Xnovate so that we can innovate. And as Frank Davidoff would say, we need to undifuse. When something's proven that it doesn't work anymore, we can use Xnovation and undiffusion as leadership tools to move our processes more quickly. In the future, I see trusting and collaborative relations, multi-professional and multi-generational teams. We'll see leaders who love their jobs, and they're able then to engage the staff in so many different ways. So my 5 lessons that I leave you with today are: we've made a lot of progress in how we improve, but we can still improve more rapidly by working together. We've learned a lot about how we hear. We are changing rapidly how we teach. We're making amazing changes in how we care, and I'll push you quite hard on how we lead. So I started this morning talking about gratitude, and a part of the reason I feel so grateful right now here today is because of all of you. I've had the great experience of being a leader of many teams. I'm the oldest of 9 children from a big Irish family. That was my first leadership lesson. And I've had many since. I'm so grateful to have had the opportunity to lead IHI all these years. But today, I'm most grateful for all of you, that together we're all here with the passion and energy to continue the transformations in care. Looking out, I see millions of Paul Bataldens and Don Berwicks, Rishi Manchandras, Jen Rogers. I see people who, each one of you will take a different message from this forum and go back and begin to transform. And I see the power of IHI in creating a global and effective learning system. I'm so grateful and I'm so joyous to all of you. Thank you so much.